So I wanted to speak today about some of the clinical implications between similarities and differences of upper tract urothelial carcinoma and bladder urothelial carcinoma. This has become a bit of a hot topic as we explore, especially the molecular biology of both entities. I have some disclosures here, none of which are relevant to today's discussion. So we know that 90 to 95% of urothelial carcinoma is in the bladder, with only 5 to 10% being in the upper tract. This makes it hard to do trials for upper tract disease, and in fact, most of what we do is either based on empiric evidence or it's actually extrapolated from trials done in bladder cancer. The question is whether this is a fair extrapolation or whether there are key differences that should impact treatment. So the things I'd like to highlight in looking at differences between bladder and upper tract urothelial carcinoma are embryology, epidemiology, clinical differences. I'm going to focus especially on molecular differences, then look at any differences we can see in response to therapy in some of the more recent trials that have been done, and finally, how this impacts clinical treatment. So first of all, just briefly to embryology, this is something that urologists all learn in detail, how the upper tract actually develops from mesoderm, while the bladder develops from the cloaca and is endoderm. So at a very fundamental level, they are derived from different embryologic layers, which may have biological impact. And in fact, for the upper tract urothelium, this goes all the way into the collecting ducts. And even the trigone of the bladder is really derived from incorporation of the metanephric ducts, which form the trigone. So you would think that potentially the trigone could be different than the rest of the bladder, but it's uncertain whether these differences in embryology are actually biologically or clinically relevant. What about epidemiology? So we see that the peak age for upper tract urothelial carcinoma is the same as for bladder and is quite different for kidney, which speaks to them having common foundations. Interestingly, bladder, as we know, is more common in men at a ratio of 4 to 1, yet is only 2 to 1 for upper tract. And the prognosis for bladder cancer is worse for women, but not necessarily for upper tract. So there are some key differences there. Most urothelial carcinoma, regardless of site, is due to smoking and some due to occupational exposures to aromatic amines and other carcinogens. But there are some special carcinogens in the upper tract, especially phenacetin, which is not used very much anymore, and ursoloic acid, which is important in different regions. Lynch syndrome is also something that's different between bladder and upper tract, or so we think. There are 6 different mismatch repair genes that can be mutated in Lynch syndrome, and upper tract urothelial carcinoma is up to 20 times more common in patients with Lynch syndrome than without. But what about bladder? And if we look at one of the largest registries, which is at the Mount Sinai Hospital in Toronto, there are 321 patients with Lynch syndrome. And you can see here that most of the mutations are MLH1 or MSH2. And the rate of bladder cancer is actually greater than the rate of upper tract urothelial carcinoma. And if you look especially at MSH2, you see an enrichment for both bladder and upper tract compared to the number you'd expect in the general population. So this raises a question whether bladder cancer is not also linked to Lynch syndrome. And this is one biologic difference that is maybe not a difference after all. Just to be clear, that an individual with upper tract disease has a higher likelihood of having Lynch syndrome. And so this is something that we think about, especially in that context. But if a patient with Lynch syndrome itself is actually more likely to have bladder cancer than upper tract, and that's something we often lose sight of. Implications therapeutically are that these patients have a high rate of the mutations are mismatch repair genes, and they would be eligible for pembrolizumab based solely on this, regardless of their actual organ of origin. What are some of the clinical differences between upper tract and bladder? So this was an interesting paper back in 2013. It was one of the first to really highlight some of the differences and to suggest that maybe we shouldn't think of both of these cancers as the same. So I mentioned that prognosis is different for men and women between the two entities. Tumor location is thought to be important for upper tract, although there is some doubt about this, and it may be more due to sampling of disease, which is more difficult for upper tract, which may cause some artifacts there. Intravesical therapy is so important for bladder cancer, but is not commonly done for upper tract. It is increasing in popularity, but it's also more difficult to do for upper tract. For bladder cancer, we think that at the time of cystectomy, that the regional lymph node dissection is so important. And we extrapolate from this to talk about it in the case of nephroureterectomy, but we don't really know what is best. And because of variable lymph drainage, we don't really know the optimal template for lymph node dissection. And finally, neoadjuvant chemotherapy, we also extrapolate from bladder. I'll come back to that in a few slides. If we look at stage and grade, there's a basic difference. 75% of bladder cancer is non-muscle invasive, and 60% is low grade. Yet if we look at upper tract, 75% is high grade, and the majority is invasive. There is, however, a potential for selection bias in the for the upper tract because it's based on nephroureterectomy, and it may also be based on some referral patterns. We don't hear a lot about variant histology in the upper tract, although we do in the bladder. It's presumably the same. It's just a lack of evidence in the literature. If we look at one large Scottish series here on the left, you can see that again, there's a higher proportion of women for upper tract. There's a higher proportion of high grade for upper tract, and there's a lower proportion of non-muscle invasive disease, just highlighting some of these differences. But let's look at some of the molecular differences. So we have a very good idea now of the basic biology of bladder cancer thanks to the Cancer Genome Atlas. This is just a summary figure here from their most recent paper. And there are some things that come out in particular. We have RNA-based molecular subtypes, which refers to sort of the luminal basal divide. And there are genes that are frequently altered, things like P53, FGFR3, and also specific gene sets such as DNA damage repair genes, which are important for response to chemotherapy and immunotherapy. And chromatin remodeling genes are frequently mutated, which seems to be something specific to bladder cancer, although we have not been able to exploit this clinically yet. So we've seen more and more papers come along over the last few years on similar molecular classification of upper tract disease, although nothing as comprehensive as the TCGA. This is one series from Memorial Sloan Kettering of 59 patients, a series from MD Anderson on 31 patients, and a review from the group in Chicago. And the data is slowly adding up, but I'd like to hone in on this one paper, which is the largest to date. It's also from Sloan Kettering, so it's an update of the prior paper. And it compares 195 upper tract tumors to 454 bladder cancers that have been sequenced on the panel of genes tested with the MSK Impact platform. So it's only DNA changes that we're looking at here. And if you look at all comers, on the left we have upper tract, on the right we have bladder. You can see that there's low grade and high grade, and there's non-muscle invasive, muscle invasive, and metastatic. So it's quite a mix. But if you look at the highest level, you see there's more P53 and RB1 alterations in bladder, but more FGFR3 in upper tract, more ERB2, which is the gene that codes for HER2 in bladder, but more HRAS in upper tract. If we go to really the only fair comparison is to divide it into non-muscle invasive, muscle invasive, and metastatic. And there also you have to be careful about grade. But if you look at non-muscle invasive alone, we see HRAS differences, and then KMT2C is one of the chromatin remodeling genes. You can see also FGFR3 tends to be higher, but is not statistically significant. At the muscle invasive non-metastatic, again, P53 and RB1 are more frequently altered in bladder cancer. HRAS, again, which is sort of a gene of proliferation in the upper tract disease, and then metastatic urothelial, again, RB1 and RB2. So there are differences depending on the disease state. However, if you look at it, I'll go back to this slide just for a second. If you look at it, it's all the same genes that are altered. There's no one gene that is popping out as being completely different. It's just different rates of the same anomalies. And this most recent paper here from Bishoy Faltis' group at Cornell distinguishes, they've actually looked at the RNA level as well as DNA level, and they've noted that there are more luminal papillary tumors in upper tract. So the RNA subtypes generally divide luminal and basal, and we know that luminal is associated with FGFR3 alterations, for example, and maybe fewer P53RB alterations. And so it really looks like the differences between upper tract and bladder are simply a different distribution among subtypes rather than truly different diseases. How does this impact response to therapy? Well, neoadjuvant chemotherapy is a very important question. We know that it works in bladder, as seen from the SWOG trial on the right here, but how does it work for upper tract? We tend to extrapolate from bladder and assume it's going to work in upper tract. The only prospective data we have is from this cooperative group trial that was published in abstract form just earlier this year, and we see very good recurrence-free survival. It's hard to interpret without a comparator arm. The T0 rate is not particularly high, only 14% compared to 38% in the bladder trial. But of course, here we don't have a TUR for upper tract. And the rate of downgrading to less than muscle invasive disease is very high at 66%. So as far as we can tell, there are certainly similarities here. Interestingly, for upper tract, although it's a hard disease to study, we actually have very good data that adjuvant chemotherapy works. And so you could say that the balance of evidence would favor adjuvant chemotherapy. The issue, of course, with upper tract disease is that nephroureterectomy is eliminating nephrons and potentially making patients ineligible for cisplatin-based chemotherapy. So most people would still push for neoadjuvant chemotherapy to ensure that as many patients as possible can get it. Responses to immunotherapy appear to be very similar between upper tract and bladder. This is from Keynote 0457, so the phase 3 Pembro trial, Pembro versus second-line chemo. You can see not much difference. Upper tract, if anything, looks a little bit better, but very wide hazard ratios. And for the Atezo data, also phase 3 trial, this is all patients, so the intention to treat cohort. There's benefit with bladder that is lost for upper tract, but very wide confidence intervals that don't allow us to really draw any specific conclusions. And if you look at PD-L1 immunohistochemistry in the Atezo trial, you can see very similar rates of PD-L1 positivity between the sites. FGFR3 inhibition has just been approved this year for bladder and upper tract disease in the metastatic setting. And it's interesting to pick out the upper tract tumors here. So these are 8 tumors out of a total of 67. And you can see that almost all patients responded or had stable disease. There's one complete response. And overall, if you look at these very small numbers, it looks more impressive than the bladder cohort overall. But I think we have to be very careful with small numbers before drawing any major conclusions here. So what are the clinical implications? So I think, first of all, we have to be careful about how we interpret the differences between upper tract and bladder. There are clearly selection biases. For example, a muscle-invasive bladder cancer may have had prior BCG, which would select for specific genomic alterations that you would not see in upper tract urothelial carcinoma. If we're excluding patients who've had neoadjuvant chemotherapy, then we may also be introducing selection bias. There are also big differences in tissue sources, whether it's bladder tumor resection or cystectomy, and whether it's ureteroscopic biopsy or nephroureterectomy. These may impact the outcomes. The ureteroscopic biopsy, for example, is a poor predictor of actual grade and stage. And upper tract disease is more likely to lead to an nephrourectomy for low-grade, low-stage disease than we would see for bladder cancer, where you really need muscle-invasive, high-grade disease for cystectomy in most cases. And as I mentioned earlier, there are also differences in referral patterns to the, most of the studies are done at the major centers in the US, and the bladders, I would suspect, are more likely to be referred to a center, whereas upper tract disease might be done out in the community more often. That's just an open question. So in conclusion, I would suggest that the molecular differences between upper tract and bladder cancer are subtle and mostly due to different relative frequencies of the same alterations. There are no dramatically different alterations. I would suggest that as we move towards an era of marker-driven therapy, that the markers will direct the therapy, and it won't matter if it's upper tract or bladder. As far as we can tell from new therapies, they seem to work just as well in bladder and upper tract with no significant differences. And I don't see a problem with us extrapolating treatment paradigms from bladder to upper tract, given the current state of our knowledge. The one exception might be the increased penetrance of mismatch repair deficiency in upper tract disease, which would be relevant for chemo and immunotherapy.